Hey there, welcome back to Between the Sheets. We are going to cover some different pelvic health issues today and some different diagnoses that you might go through in the pelvic area for both men and women. So, going to be a couple variety of topics here, but all surrounding issues in the pelvic area. So, starting with one for my guys, hard flaccid syndrome. Hard flaccid syndrome is a male sexual dysfunction that causes pelvic floor muscles to tense and contract. So it's poorly understood. It is a syndrome that is characterized by chronic pain, a partially rigid penis when in the flaccid state, sensory changes, mostly at the glands of the penis, and also some erectile dysfunction. There are also reports of having the pain exacerbated during ejaculation and urination. So sometimes that pain can be worse during those times. This primarily affects men in their second to third decade of life. And the hypothesis that is most commonly thought of or learned used is that an initial traumatic injury to the base of the penis typically occurs during intercourse. So damage to this neurovascular bundle that supplies the nerves to the penis and the pelvic floor. It is thought to be an emotional reaction following the injury and the noticing of the sensory changes on the penis, which cause a feedback loop where there is this reaction trigger. It's a hypersympathetic response leading to pelvic floor muscle spasms. And these ultimately cause additional damage to the nerve bundles that are in the penis. So how might you know you even have this issue, or what are the symptoms of it? It would be difficulty getting or maintaining an erection, pain in the pelvic area, discomfort during sexual activity, and difficulty urinating or having a bowel movement, significant anxiety and depression, and significant impacts on quality of life. So it can cause stress, anxiety. Those can also be causes of the issue, stress and anxiety. You can have overuse of the pelvic floor muscles, which can cause this, nerve damage or a neurological disorder. Obviously, a traumatic injury, those can all cause this hard flaccid syndrome. So for treatment of this, although it is poorly understood still, and there's not any evidence-based guidelines for treatment, we kind of think this multimodal approach, multiple modalities coming together, combining both pelvic floor physical therapy, muscle management, some pain management, lifestyle modifications. The combination of those things have been effective. So behavioral modifications, biofeedback, cognitive behavioral therapies, pelvic floor physical therapy, breathing exercises, some yoga, some pain medications, the PDE5 inhibitors that we use for erectile dysfunction have been helpful, and also some antidepressants. So this is a definitely an issue. It's also hard to diagnose. I've had a couple guys who maybe have this in clinic. It's just one of those. It's kind of a diagnosis by elimination. You don't just solely have erectile dysfunction. You do have some anxiety and stuff going with it. You maybe did have an injury, and you're kind of piecing these things together. And when you've eliminated other issues, then you're kind of like, you know what, this is fitting hard flaccid syndrome. Where the pelvic floor physical therapy comes in is it helps to relax the muscles of the pelvic floor and then also strengthen them. And you can practice these exercises at home. You can discuss the frequency and the number of these, etc., with your physical therapist, because you don't want to make things worse. And if you overdo certain exercises, not do the relaxing parts of it, then it's not nearly as effective as if you are working with a therapist who's giving you a plan to follow. For the behavioral modifications, we want you getting good sleep hygiene. We want you to have good sleep hygiene, so you're getting good quality sleep, healthy eating, regular exercise, reducing stress, and improving your well-being, getting your other comorbidities under control, like your blood pressure and your diabetes, etc. Those things can really be helpful for getting that done. New advances within physiotherapy rehab focusing on tailor-based pelvic floor muscle re-education. This combined with graded activity exposure, education, stress and lifestyle management, this is showing that can be most effective in decreasing the clinical symptoms as well as the social, and sexual function of the individual. So that's one that can definitely affect our guys. We want to be sensitive to that, work on that with them. But also just knowing that this syndrome is out there helps, because you might be having these various issues and not really sure exactly what's causing it. And we can certainly help you with that if you're going to a urologist, pelvic floor specialist, etc. Another one that comes to mind that can be for both men and women, I see it happen more in women, but it definitely affects both, is pudendal nerve entrapment. So the pudendal nerve is in your pelvis, and you can get a chronic pain condition that occurs when this pudendal nerve is compressed or entrapped within the pelvis. It's also known as pudendal neuralgia. So just to kind of give you an idea of where this is coming from, the pudendal nerve comes out of the nerve roots of the sacral nerves 2, 3, and 4. And this is coming out of the sacral plexus. So you think of like your butt bone area. It carries sensory, motor, and automatic nerve fibers. The injury to the pudendal nerve can cause more sensory effects than motor effects in most cases. It initially occurs between two muscles, the piriformis and the coccygeus muscles, and then departs the pelvic cavity into the greater sciatic foramina and down through the leg. So it does pass medial, so inside, to the sacrospinous ligament of the ischial spine. So then it re-enters the pelvic cavity through the greater sciatic foramen. The pudendal nerve then courses through the pudendal canal, or it's also called the Alcock canal. And so this is where you're seeing that pinching and possible injuries, or the fossa gets too narrow. These can interfere with the rectal branch, the perineal branch, and the dorsal sensory nerve of the penis or the clitoris. So you can get sexual dysfunction as well as chronic pain from pudendal nerve entrapment. There is variability in which one gets pinched, which part of it gets pinched, what your syndromes are, based on each individual's anatomy and where the pudendal nerve is coming in and out of specifically for that patient. The pudendal nerve entrapment syndrome subdivided into 4 different types, so type 1 through 4. Type 1 is the entrapment is below the piriformis, and the pudendal nerve exits the greater sciatic notch. Type 2 is the entrapment is between the sacrospinous and the sacrotuberous ligaments. This is the most common site of pudendal nerve entrapment. Type 3 is the entrapment in the Alcock canal, and then type 4 is entrapment of the terminal branches. So this can arise from both mechanical or non-mechanical injuries. A mechanical injury could be due to compression, transaction, or stretching. This could it usually is the most common etiology of the pudendal nerve entrapment is mechanical issues. The non-mechanical causes of pudendal nerve entrapment include viral infections like herpes zoster or HIV, multiple sclerosis, radiation therapy, diabetes, and other comorbidities that can increase this risk. So causes of pudendal nerve entrapment could be from pelvic surgery. So surgery for the repair of prolapse of pelvic organs is reportedly the most common cause of pudendal neuralgia. The incidence increases if a mesh is used. Chronic persistent pain may require the mesh to be removed in another surgery. It can develop in the mid-urethral sling surgery, a hysterectomy, or an anterior coloporphyry. The direct trauma to the buttocks or back can result in pudendal neuralgia. Childbirth, so a vaginal delivery causes significant stretching of the pelvic floor muscles, and sometimes this leads to pudendal nerve damage. Chronic constipation can cause this. So really having a good bowel regimen and having regular bowel movements is important. And then excessive cycling. So this sitting for hours and putting pressure on the pudendal nerve causes microtrauma. And it causes this fibrosis, in the pudendal canal, as well as the sacrospinous and sacrotuberous ligaments. And that can cause the pudendal nerve entrapment as well. Prolonged sitting can also contribute. So think about your drivers, delivery guys, truck drivers, anybody who drives for a living that may be going in long distances. So that could certainly contribute as well. So what are some of the symptoms that you might feel if you have this pudendal neuralgia? Pain in the lower body, especially in the perineal, genital areas, the perianal area as well. Pain that worsens when sitting and improves when standing or lying. It is usually burning or sharp pain, numbness, a pins and needles type feeling in the perineal area, a swollen feeling or feeling of a foreign body sensation in the anus, the rectum, the urethra, or the vagina. Urinary issues such as urgency, frequency, and painful erections for our guys. Sexual dysfunction, including persistent arousal dysfunction, pain with sex, pain in the perineal area, that's vulvodynia, and then male erectile disorders as well. Sphincteric dysfunction presents as constipation, pain with urination, fecal incontinence, and urinary hesitancy, meaning a difficult time getting that stream going. Pudendal nerve entrapment is often misdiagnosed or undertreated, which can delay proper treatment and negatively impact quality of life. The incidence of the condition is 1 per 100,000. The actual prevalence is believed to be substantially higher, but not a lot of people get the treatment or the appropriate diagnosis. The pudendal nerve entrapment syndrome may affect 1% of the general population and accounts for about 4% of all patient consultations for pain control. Women are affected twice as much as men. So what are the workup? They use the criteria of that the pain correlates with the anatomical distribution of the pudendal nerve. So meaning that the genitalia and the perineum are being affected by this pain. The pain is predominantly when you're in the sitting position. This symptom favors nerve compression because the decrease in the nerve mobility from sitting can cause compression trauma. So it's very important that the pain is worse while sitting. The patient does not get up at night due to the pain, although a lot of patients have difficulty going to sleep because of the pain. So it's not pain that wakes you up. There is no identifiable sensory loss. So you can still feel everything. It just may change how you feel things or what you're feeling. Relief of pain occurs with a pudendal nerve block. So this is essential for the diagnosis. Any perineal disease other than entrapment can cause pain in the area, but a nerve block can help identify that it is a pudendal nerve issue and not something else. A negative block doesn't necessarily exclude the diagnosis of entrapment, but if the block is placed correctly and done right, it should give you good relief if it is an entrapment issue. So exclusion criteria for this diagnosis would be pain exclusively in the territory not served by the pudendal nerve, so the coccyx, the pubis, the gluteus areas. Pain associated with itching, that's probably more suggestive of something going on with your skin. Pain that is entirely paroxysmal in nature, imaging abnormality that identifies the cause of pain. So obviously those would all be reasons that it would not be pudendal nerve entrapment. So what are some treatments that we can use? Physical therapy to stretch and relax the pelvic floor muscles. It's usually 6 to 12 weeks. They can use TENS stimulation. It's low risk. It's relatively inexpensive, and most physical therapy offices have them. You can even buy them online if that is suggested to you by your physical therapist. Lifestyle changes such as standing or sitting up more straight, avoiding triggering activities. So that might mean if you're a cyclist that you need to take a break from cycling, maybe work with your physical therapist to find a different bike seat, something like that that can help you kind of maintain your lifestyle but protect the pudendal nerve. Roughly 20 to 30% of patients will see relief from conservative measures alone. We also do have some prescription medications that can help. So muscle relaxers, pain medications, and anticonvulsants. These have been studied in randomized. There are no randomized control studies, but they have studied these drugs to see relief. And so several medications and drug classes are used, and it's usually a combination of medications like a tricyclic antidepressant, an SSRI, or a neurotransmitter analog like gabapentin. Opioids are not used very much. We worry about the opioid epidemic and people getting addicted to them. So we definitely want to be very careful. Some of the medications that we'll see: amitriptyline, duoxetine, gabapentin, pregabalin, and clonidine. These are all frequently used for pudendal nerve entrapment. The pudendal nerve block is a local anesthetic and steroid that goes into the pudendal nerve, and that is a short-acting anesthetic that starts working within 20 minutes or less, and then a longer-acting one that can last for 3 to 5 days. Some people process it very slowly, and it can last up to a month. About 25% of patients report pain relief lasting more than a month following the block. So it doesn't work long-term. The injections get less effective over time, but it can be really good relief, especially if you are in a lot of pain and then you're also trying to adapt and develop some of the lifestyle skills, going to pelvic floor physical therapy. Sometimes it can just give you that relief until you get there yourself. There is also surgical decompression surgery, which is a surgery that frees the pudendal nerve in the Alcott canal. It is very effective for long-term treatment, potentially a cure for pudendal nerve entrapment. Obviously, you're going through surgery, so there are risks associated with that. Sacral modulation. This is a minimally invasive treatment that includes a peripheral nerve stimulator that helps the nerve regulation of the signals from the pudendal nerve so that you don't feel the pain to the way that it is. Pulsed radio frequency ablation. So this is a newer method for pudendal nerve entrapment. We've been using it for years and years for other nerve issues, especially spinal nerves issues in the lower back, and it works very well for that. So they've been working on it with the pudendal nerve. It's considered safer than continuous radio frequency, and it uses this pulsed magnetic radiation, and it is potentially useful for chronic pudendal neuralgia when other treatments options haven't worked very well. So it tends to work longer than the block, usually 1 to 3 months. And several studies have shown that there is persistent pain relief in 89% of the patients that were studied in this one study of 90 patients, and that was followed for 6 months. So even at 6 months post ablation, the effect was 89% of the patients still had pain relief. So that's amazing. You really do want to, consider patients who you've seen in the past. If you're not aware of the pelvic nerve entrapment, if they have chronic pelvic pain, you want to bring them in and kind of reevaluate them for this if you can. So definitely one that can affect both male and female there, but a lot of times I see it in females where we're just not really figuring out what is causing their pain. And then as we narrow it down, we can figure out that it's this pudendal nerve. So another pelvic health area that we can talk about is vaginismus. This is a condition in which the involuntary muscle spasms interfere with vaginal intercourse or penetration of the vagina. So this often results in pain for attempts with sex or putting in a tampon. It often begins when vaginal intercourse is first attempted. Vaginismus is considered an older term. A lot of people now are just saying pelvic floor dysfunction. I like using the term because we consider a lot of things pelvic floor dysfunction. So this helps narrow down which area you are having dysfunction in. The unintentional muscle spasms occur when anything is attempting to penetrate the vagina. So whether that is a penis, a finger, a tampon, medical equipment like during your annual exam, these spasms can be mildly uncomfortable or severe pain. There's a lot of room in between. Healthcare experts we're not really sure why people experience this. Physical and psychological, social issues, bladder infections, yeast infections, these can all worsen the area. So whether it is originally created by some trauma and some psychological issues, or if it is a purely physical thing that then causes some psychological and sexual issues, it's a back and forth discussion as of now. Factors that we think contribute to vaginismus: anxiety disorders, childbirth injuries, vaginal tears, prior pelvic surgeries, fear of sex or negative feelings about sex, past sexual abuse, rape, or trauma can do this as well. So signs of vaginismus include discomfort or pain during vaginal penetration. Again, this doesn't have to be penetrative sex. It can be with an exam, with a tampon use, fingers, anything that goes near the vagina that causes these spasms to kick up. It is the inability to have sex or a pelvic exam due to the muscle spasms and painful intercourse. So how do we diagnose this? A pelvic exam can help rule out other problems or confirm that a presence of muscle spasms. Your provider can apply a topical numbing cream to the outside of the vagina before the exam to make it more comfortable for you. So there are some treatment options. There's things that we can do to make this get better for you. There are topical numbing agents like a topical lidocaine or a compounded cream that can help with the pain associated with this condition. You can go to pelvic floor physical therapy. They can teach you how to relax the pelvic floor muscles so you're more accepting of something into the vagina. You can use vaginal dilators. So they come in various sizes, very small to slightly larger. Their purpose is to stretch the vagina. So patients with vaginismus use these dilators to become more comfortable with, less sensitive to vaginal penetration. So you start with the smallest ones and you work your way up until you are able to do the activities that you would like to do. So sometimes we will suggest that you use the numbing cream when you're getting started to make the insertion easier and help decrease that pain as you're really just starting off. Usually once you've done a couple of the dilators, you can start to tolerate a little bit more without the vaginal lidocaine or topical lidocaine. There's also cognitive behavioral therapy. This helps you understand how your thoughts affect your emotions and behaviors. It's very effective treatment for anxiety and depression and post-traumatic stress disorder. So a lot of times if it was something traumatic that occurred that is responding in this way in your pelvis, that this cognitive behavioral therapy can help. And then there's also sex therapy. Trained sex therapists work with individuals and couples to help them find pleasure again and be able to explore intimacy and sexuality in their relationships. So those can all really help work through this painful condition that vagina holders can have. Another one for our vagina holders is vulvodynia. Vulvodynia is a chronic condition that causes pain, burning, or discomfort in the vulva. The external female genitalia is what a vulva is. The pain can be constant or come and go. It can be felt in one area or across the entire vulva. It is diagnosed when symptoms last at least 3 months and there's no identifiable cause. Vulvodynia can make it difficult or impossible to sit for long periods of time, to use tampons, or to have sex. It can affect women of any age, but is most common in women, young women who experience pain during sex. Some possible causes of vulvodynia: nerve damage or irritation, vulvar inflammation, long-term reactions to infections, genetic disorders, food sensitivities, and pelvic floor muscle dysfunction. So there's no known cure for vulvodynia, but a lot of the therapies help to relieve the pain and the symptoms. So medications, we can use anticonvulsants, antidepressants, opioids, topical creams or ointments. We want our ladies to have really good hygiene. So unscented, soft white toilet paper, 100% cotton pads and tampons, avoiding deodorant tampons and pads, not putting any soaps, lotions, powders, douches in that area, and just really keeping your vagina and the whole vulvar area as clean and product free as possible. And then some other remedies, you can use Epsom salt baths, wearing cotton underwear during the day, applying cold compresses or gels packed to the vulva when the pain is getting severe. So definitely something that we can continue to work with for you. Pelvic floor physical therapy, again, for this one is another great option. Going back to our penis holders, painful night erections, also known as sleep-related painful erections. It's a rare condition that causes deep penile pain and disrupts sleep. So it's a painful erection that occurs during rapid eye movement or REM sleep, with painless erections when you're awake. So you only have pain with the erection when you're asleep. It affects about 1% of people with sexual dysfunction. The exact cause is unknown, but some possible causes that we think are there: increased testosterone levels, altered autonomic function, compression of the lateral preoptic area, psychosomatic factors, disturbances in neurotransmission, and obstructive sleep apnea. You're going to have a painful erection that wakes you up from your sleep. They might have frequent awakenings, anxiety, tension, and irritability during the day as well. So diagnosis a lot of times is delayed because people are guys with this condition. They don't necessarily talk about it. They fear being impotent. And it definitely requires comprehensive urological and endocrinological evaluation. So we're looking at your hormones, we're looking at your anatomy, we're listening to when you have the pain so that we can help you get the correct diagnosis and work through these issues. There's no single effective treatment for the sleep-related painful erections, but some treatments have been tried that include muscle relaxants, antidepressants, benzodiazepines, and antipsychotics. Sodium oxybate is a newer therapy. It might be effective for this. Muscle relaxants like baclofen and pregabalin or Lyrica are also used as first-line treatments. And then we got to talk about coping strategies, reducing stress and improving emotional coping mechanisms during the day that may help reduce sleep disrupting events at night. Cognitive behavioral therapy for insomnia may also help. If their testosterone is too high, do we need to manipulate their levels and get them, at a better level for that? So, working through all of that with a therapist, without a therapist, with your urologist, your endocrinologist, your pelvic floor specialist, all of those are really great ideas. For our female patients, genitourinary syndrome of menopause. This is one that's getting a little bit more attention now, but deserves a lot more attention. So genitourinary syndrome of menopause, it is basically, as we go through menopause and after menopause, we stop making estrogen. And the estrogen for our pelvic area is very important for blood flow, for, the thickness of the tissues down there, for the lubrication of our tissues. So it helps prevent infection. It helps give us less irritability of the tissues down there. There's so many things that estrogen does for our vulvar health. And so the genitourinary syndrome of menopause is the lack of estrogen causing these symptoms. So a lot of ladies will start to have pain with sex, dryness, frequency and urgency of urination. Sometimes they'll have pain with urination or just random pelvic pain. Lots of different things, just some real irritation in the vulvar area. And so the best thing that we can do here is improve our hygiene, no products in that area besides water and what I'm about to tell you, as well as, just real good cleanliness and good products like estrogen. So replacing a little bit of estrogen topically in our vaginal vulvar area is really important to bringing this health and vitality back to these tissues. There is very, very minimal risk of blood clots and cancer, which are the biggest things that we think about with hormone replacement therapy. This is not a systemic hormone replacement therapy. It is only going to the vaginal tissues. It does not affect the blood level of estrogen. And so it's not going to help with your hot flashes or your mood swings or your brain fog. It is specifically going to help with the issues in the perineal area. So you put it on a couple times a week. You can use coconut oil or a different moisturizing product specifically made for this, like Replens, on other days of the week, but the twice a week, sometimes we'll do 3 times a week, depending on your personal needs. And it really rejuvenates the vaginal area. You get thicker tissues, better blood flow, decreased risk of infection, decreased risk of those tissues tearing, less urinary symptoms. So the frequency and the urgency are going to be cut back. The pain with sex is going to be cut back. So that's a really great utilization of vaginal estrogen. I also send my ladies to pelvic floor physical therapy to help relax these muscles, strengthen the ones that they need to strengthen so they don't deal with things like stress urinary incontinence with coughing, laughing, sneezing, and those kinds of things. We also talk through bladder irritants, pelvic irritants, so that we can cut back on those while we're also using estrogen and pelvic floor physical therapy. The other one for our vagina holders is pelvic organ prolapse. So pelvic organ prolapse is when one of your organs is falling into the vaginal area and sometimes out of your vagina if it's very severe. So that could be your rectum, which is called a rectocele. That could be your bladder, which is called a cystocele, or that could be your uterus falling down. Any of these things need to be remedied. If it is your bladder and the bladder is tipping into your vagina, there is usually some retention of urine, which makes you at higher risk of infection. And so we want that bladder pushed back up into its right position, whether that is by surgery or a pessary. And so that we decrease your urinary symptoms with that. So that surgery might be a hysterectomy and bladder sling. It might just be a bladder sling. It might be using a pessary, and I'll explain the pessaries here in a little bit. If it is your uterus prolapsing, depending on the degree of prolapse, we can use one of the pessaries. You could have a hysterectomy. You can have a tightening of the vagina. There's various surgeries there. A urogynecologist or OBGYN is really good to see for those issues there. Rectocele is where the rectum is pushing into the vagina, and that can be with severe constipation. It can have bowel issues. It can be very painful, and it can also make having bowel movements very difficult and having to strain. So pelvic floor physical therapy comes into play here to keep everything as functional and healthy as possible. The pessary is a disc that is plastic, and there are various types of them. So some of them are flat, some of them are rounded, some of them are thick like a donut, some of them have a little stem, but basically we put them into the vagina and at the top of the vaginal canal, where that would be where your cervix is, or if you've had a hysterectomy, where your cervix was. And we put it up there and it kind of holds the vagina taut. So it pushes the cystocele back, it pushes the rectocele back, it holds the uterus up if you still have a uterus, and it does a very good job. There are some caveats. We don't want you having sex with a pessary in. So if you are still sexually active, we are limited to what type of pessary we can use in you because you need to remove it for sex. Some women are just between sizes and the pessary doesn't work for them. So they are more likely to be a surgical candidate. But I have women who use pessaries for years and years. My oldest patient I ever had with a pessary was 105 before she passed away. And so they do work very well, and they're really a game changer for women who, especially for me, that I see is with the cystoceles, with the bladder issues, getting that pushed back up and being able to eliminate correctly and decreasing your recurrent UTIs. It's been life-changing for a lot of my ladies. The ones who have the severe prolapse where their uterus is basically hanging out of their vagina, that's very uncomfortable. It's dry, you're wiping and you hit it, you're sitting and you feel like you're sitting on it. So using a pessary or having a hysterectomy can be really important for that. And obviously, if you have things prolapsing into the vagina, that's making sex difficult or not even doable. So the more that we can help you with that, the better that we can keep you having sex and enjoying that intimacy with your partner. It's time for my favorite segment of the show, Between the Sheet Shenanigans. We've got some great stories for you, and as always, the details of the stories will be changed so that you cannot identify who the owner of the story is. It might be my story, might be my friends or family members, or even a patient's story, but you're not going to be able to tell. Please send in your stories as well so we can shake up the details and share your stories. Send them into podcastbetweenthe_sheets@gmail.com. Let's tell some stories. All right, so I have some good stories here. I had a patient who he knows I'm going to be talking about this. He gave me permission to tell his story. So he knows I have the podcast and talk about stories. I had a patient who was using his cock ring at home and put it on, and then he tried to also wrap it around his scrotum, and it was not a cock ring made for that. You do need to get specific cock rings if you're going to use one around the scrotum and the penis. Otherwise, they are just made just for the penis for most of the time. So he had put this on and he could not get it off. It was too tight. He had left it on for about 15-20 minutes and his penis was turning purple. It felt cold to him, although to touch was normal temperature. He tried so many different things to get this off. He even tried kind of like jumping onto the bed and kind of trying to get his penis to squish so that the erection would go away and it could maybe come off then. He did do a little damage to his penis by doing that, but eventually he was able to get it off. He did come in and see me afterwards. There is a little bit of a plaque, like a Peyronie's issue, but I think overall he will heal well from that. But if you're going to use a cock ring, make sure it's an appropriate size. If you're going to wrap it around the scrotum, make sure it's one that actually is made for that. Otherwise, just put it around your penis and go buy another one that goes around the scrotum as well, if that's something that you want to try. I had a patient for the vaginismus, the spasms in the vagina. She had pain putting in a tampon. She could barely get the tampon in. She really couldn't even tolerate being fingered. She wouldn't even try sex. It was just so painful for her. And that was really disruptive. When I met her, she was in her 20s. So she was at the prime where she wants to be doing things. She wants to start thinking about a family and having children. And she just couldn't even fathom that if she can't even put a tampon in or get fingered. And so we did some techniques with her for pelvic floor physical therapy. We got her a sex therapist as well to kind of talk through some of the emotional side of things. And then we ended up using some vaginal dilators with her, some good lubricants. We did use a topical lidocaine on her for getting her more used to using the dilators and getting that stretch in there. And it was very successful for her. It took about 6 months to get her to where she could accept a penis for penetration. She has a great sex life now. She doesn't have pain. She understands all these techniques and is doing very well with them. So that was a great outcome for a painful situation. I had a patient who had pain during sex, and they went to, that was the only time that they had sex. They were fine going to the bathroom, all the things, but with sex was very painful. Sent to pelvic floor physical therapy. Her muscles were just so tight. When I did an exam on her, it just felt like she was almost bearing down, and she wasn't. That was just how tense she was. And so pelvic floor physical therapist, actually, I learned from them, they had suggested using an anal plug for her, which kind of helped pull the muscles in a different direction, and that she learned how to accept that and take that. They had her use the anal plug during sex, and this helped her muscles relax, and she was able to take the penis then in her vagina, and ended up doing very well with that. And a couple years later now, I believe she's not even using the anal plug anymore. She's been able to kind of overcome all of that, get her muscles stretched out and relaxed, and has continued to do her pelvic floor exercises at home, so that this continues to do very well for her. And then another thing that I had a friend of mine tell me about was, she calls them butt pains. And she can remember even as a teenager having this issue where felt like she needed to have a bowel movement, and then the pain was just so intense internally by her anus, like between her anus and her hip bone. It's kind of how she described it to me. And the pain was so intense, it made her feel nauseous, like she was going to throw up. Having a bowel movement didn't really help, but it just had this strong feeling of needing to have one. And she would have to kind of massage that area, get into certain positions. And it ended up being a pudendal nerve entrapment. Did physical therapy. She did get diagnosed by using a block, so we knew that that was what was going on. But now she has her exercises that she does regularly to prevent that, and tells me she only has like a flare maybe once or twice a year now, where she was having them several times a month, and it was really disruptive. It would come out of the blue. It would wake her up from sleep. Sometimes it was while she was working, and it was just really disruptive. So she was happy to find these interventions that were able to take away this pain. So thank you for joining me today and listening to these various pelvic conditions. I hope you took some pearls of wisdom today, and we'll see you next time on Between the Sheets.